further enhance our clinical acumen and decision making. With that energy and enthusiasm carried forward, we now commence day 2 of our conference. Today's agenda features an eminent lineup of expert speakers and distinguished chairpersons who will help us delve deeper into the nuances of shoulder and elbow surgery. We will cover pulse of proximal humerus plating, discuss challenging fracture cases, explore reverse shoulder arthroplasty, and highlight essential topics including superior capsular reconstruction, slap repair, and rehabilitation methods. With that, let us begin session 1. I humbly invite our respected chairpersons, Dr. Kamal Arora, Dr. Parampreet Singh Nagpal, Dr. Hari Om Agarwal, and Dr. Parminder Sarkola to kindly grace the stage, take charge of the proceedings, and extend the honor of introducing and inviting the speakers of this session.
Very good morning to all of you. We are going to start with the first session of today's academic event, and the first talk is being given by none other than Dr. Devendra Chauhan. He is orthopedics at PGI Chandigarh and most experienced surgeon. He is expert in arthroscopy, arthroplasty, and trauma surgeon. And now I invite Dr. Devendra Chauhan to share his case with the audience and highlight them about his tips and tricks regarding management of the proximal humerus fracture. Dr.
Thank you very much, chairperson and organizers and all the seniors here. So the objective of my case discussion is that we will discuss all the cases, different kind of cases with head split fracture in the proximal humerus, and we will try and understand what is the differences in the heterogeneity of head split fracture in proximal humerus. And most of these patients are young patients belonging to 18 to 50 years of age, and sustained fracture following a road traffic accident, and they have minimum of 4, maximum of 12 years of follow. So when we see a case like head split fracture, what to do? So either we go for osteosynthesis, we do hemi, we do reverse shoulder. So before I start, I want to ask some of the senior faculties here. Dr. Ravi sir, what will be your comment about cases like this when we have a split proximal humerus fracture? Head split proximal humerus fractures. So word from senior that preserve the head. Dr. Mittal sir. Dr. Ravi sir. Yes.
If he is in the elderly age group, I will go for either hemiarthroplasty
Okay.
I will go for MRI to see the condition of the rotator cuff.
Okay. Even in the acute trauma with a head split fracture.
Those are having good rotator cuff muscles, then hemiarthroplasty only does very well.
Okay.
Because it is the rotator cuff which has to move the hand.
Okay.
So if the rotator cuff is bad, then reverse shoulder replacement in elderly.
Okay.
In young patient, yes, you should
Osteosynthesis.
preserve.
So age is the major criteria. If it is young, preserve the head. Dr. Maheshwari.
Let's see, what is the importance of head split? Importance is the head, which is also a split, a fracture 4-part, for example,
Yes.
and the head is split. You have a very high chance of one of that partial fragment to become avascular.
Yes.
Much higher chance.
Yes.
So it is not the head split, it is whether the propensity of that part of the head
Yes.
becoming avascular. For example, in your case, the one that you showed,
Yes.
both the components have good vascularity. One has big GT, one has big shaft. So if you fuse them, then you, even in an 80-year-old, I will fix that fracture.
Yeah. I think it's a very valid point by Dr. Maheshwari. What is important? Know the vascularity. Okay. So if you look at the literature, recent one, I think I gave the task to Dr. Shivam here from the AIIMS BATHINDA to find me some relevant articles, and he found this article yesterday night only. And if you look at the conclusion, the first line, if you look at the first line, what is it is written that head split fracture or if shows high complication and revision rate. But often we forgot to read the second line. The first line set our brain that yes, or if is going to give lot of complication. What is second line? Results of reverse shoulder and or if both are same. And I will elaborate the problems in this article later after my case discussion, what were the problems when they made the conclusion. And during this talk, all these cases were operated using deltopectoral approach. And what was done? None of the tuberosity was erased. Neither the lesser tuberosity, no subscapulary erosion, no erosion from the GT side. Because as Dr. Maheshwari said that it preserved the vascularity. The LT and GT are actually the vessels to the head. So how to approach head split is open the rotatory interval, retract the subscapularis anteriorly and supraspinatus posteriorly, and that's how we can expose the head and we can see the split head. It is the first case. He was a young patient, had an open proximal humerus fracture with split, as we can see here. And what will be the approach? Like all the open fracture, what we do is primarily do a debridement, good debridement, decontaminate the wound, and once the wound is decontaminated, stage or primarily do the osteosynthesis. And because shoulder is a vascular structure, the problems with the like in the tibia, we don't have a problem of avascularity and skin necrosis. So what I opted, like in any case with the articular, do the CT scan to understand what is the fracture morphology. Here we can see the head split, and the head split type we can see that there is an anterior fragment which is dislocated outside anteriorly, and there is a congruent posterior fragment. Then as it was an open fracture, how to extend that wound, what are the fixation options, and what may go wrong in these kind of cases. Dr. Mishra, would you like to add any comment in this case? So this was the X-ray and wound, and this is the CT scan. He was, I think, around 42.
So this is severely contaminated and infected, most probably.
Yeah, contaminated, yes.
Contaminated. And head doesn't seem to be reconstructed.
If it is minimally contaminated, I'll fix at the same time, otherwise I'll go for the second time.
Okay. Dr. Ravi?
Was axillary nerve normal?
Yes, neurovascular was
The
normal.
wound was.
In all the cases, neurovascular status was normal. It was a general statement. Yes.
So I go with Shashank
Okay.
because I feel it's not reconstructible. There is combination in the anterior split part also.
Okay.
I would debride and do a minimally fixation, like maybe per K-wise.
Okay.
Just reconstruct the head to as best as possible,
Okay.
and minimum fixation because there is a high chance of infection if I do too much surgery. And I know this patient may not do as well. It may get avascular,
Yes.
but my GT etc. would have healed by then, and I'll bail out with a good heavy later. If I do heavy primarily within a week, 10 days, then chances of getting the union of the GT will be a problem.
Yes.
So I will take a chance, number one, for the patient, give me a choice. After 6 weeks, 8 weeks, 2 months, he can say, I'm fine, it's okay, I don't care about AVN. But if they are symptomatic, then
Was like this, and we reconstructed the head, and because shoulder is a very vascular structure with a thick soft tissue cover, so we went for primarily open reduction. And in this case, the abdomen was also broken. We possibility of avascular necrosis. Unfortunately, infection doesn't happen in this case after thorough debridement and single stage of the fracture healed, and there is some amount of default.
कल होगा तो आज replace कर सकते हैं.
True.
But AVN of shoulder is very different from the AVN of the hip.
Very
It's a
true.
non-mid-bearing joint.
Yes.
I had my own patient.
Replace करते हैं, yeah. So yes, Dr. Mishra.
It's a scapulothoracic movement mainly.
Yeah.
Yeah.
There are a lot of scapulothoracic
And
movement
I
here.
think the requirement of every patient is
Yes.
this.
You will
That
wait
depends-
once it heals, because as Dr.
That
Mishra-
depends, like if the wound is not too contaminated,
Yes.
then there is no harm in doing primary.
Okay.
But one has to be very cautious. If you want
But
No, no.
no, I'm just saying that you did almost the same thing apparently to most
Yes.
of the people.
Yes.
But what is the big difference between what he wanted to do and what is done here? Is he said minimal fixation.
Yes.
Minimal fixation.
There is a risk of AVN. We should stay away from any locking implant, because keep them short screws or maybe non-locking options. So this patient had partial AVN, and we can see that patient didn't had a great outcome, but still we can see that moderate to fair outcome on the constant score was observed in this case. GT, but it is not displaced. We can see the head here. On the axial section, we can see head with LT. That means blood supply of the head of humerus, and thereafter we went in, we did open reduction, but yes, that is the best option at that time. And this is when I get, because when we have a displaced fragment, it is not possible to identify each and every axial section of the humerus. Very good outcome, especially in this case. There is a little bit loss of the abduction, but rotations are nicely preserved, and the patient is doing until now doing good. Again, a case of head fracture with posterior dislocation. This is a head fracture with posterior dislocation without any tuberosity involvement. So these are very rare case, and there are only few case reports published in literature. And if you look at the CT scan, we can see that head is dislocated posteriorly, and it's only a fracture.
Age क्या?
Okay. Okay. Yes. ये चलना बंद हो गया शायद. ये चलना बंद हो गया. हाँ. Yes. Working. Yes. Yes. So in this case, if we look at the tuberosity, both the tuberosities were healthy, intact. So we may ensure the result even with the hemi. But if you look at the case report from the same kind of fracture, there are 8 cases reported in the Europe, and they have identified that the risk of AVN are not that great. Even in that series, only 2 had AVN, but they didn't require the future surgery, or maybe they didn't opt for future surgery. So that is difficult to say based on the case series. But this is what happened in this case. This is what we reconstructed with the headless screws. And intraoperatively, we identified that some part of the tuberosity was also broken. There was a crack going on from in the LT. So we stabilized the LT just to support the head. Yeah. It was, I think, it was long back. When I was associate professor, it was at that time. It's been
so
10 years.
it was only head fracture?
Only head fracture.
No neck fracture.
No neck fracture.
So that's a different situation.
Yes. Yes.
So I want to make a comment here because we are discussing about fixation and then locking plates we also discussed. I'll narrate a case which I operated last year. An elderly lady, she got Philos plating, locking plates from somewhere, and then the screws went into the joint. She came to me for the treatment, and I decided to do reverse shoulder replacement. So when I opened, all the screws were jagged, cold weathered. So my request to all the surgeons is, whenever you do locking plating, please think that someone has to remove it later on. And it was a desi plate.
That's the
So
problem.
that makes all the more difficult.
Basically.
And then I struggled a lot in removing the screws and the plate. And I did the reverse shoulder replacement. In the ward, after around 2 hours, there was no circulation in the hand. So we went in again in the evening. We found a thrombus in the brachial artery. CTVS surgeon was there, Dr. Rana, PGI ka hi hai. And then thrombectomy was done. At 2 a.m., she again developed the avascular hand.
Okay.
So next morning we got the CT angio, and in the meantime brachial plexus had also gone because avascularity for a long time was
So
there.
many complications can happen.
And then ultimately the patient said कि मेरी amputation कर दो, but we counseled कि इसके जो है stent डलवा देते हैं. Dr. Bali put a stent. The hand survived, but ultimately brachial plexus took 1 year to come back. So the one small thing ना, people say कि एक बारी बाद में फिर कर देंगे. मतलब कई बारी ऐसी प्रॉब्लम्स भी आती हैं कि एक सर्जरी बेटर रहती है if we think well.
That's what evolution is. That we are evolving with the more cases we are doing, and we know that head split fractures are not a very common scenario. And yes, sir.
This fracture can be is a osteochondral fracture.
Yes.
Comparable to the osteochondral fracture of patella or
Yes.
condyle.
It's like
What
that.
do you replace knee? Do they ever undergo avascular necrosis? The fixed fragment?
No.
No. Then why should here?
Yes.
अरे वही है ना सर उसमें भी नहीं है फिब्रल कंडाइल में क्या है फिब्रल कंडाइल में क्या है
So it's a big osteochondral fracture, and it's big. Actually the race it's actually the race between the biology that if fracture heals first before it collapses, then probably it's going to give a good result. So if we can compress the fracture nicely and we get a, because the healing there is going to happen is by direct healing. There will be no indirect healing. It's an intra-articular. So you have to compress the head very nicely into the bed, and there should be allow a rapid direct healing. And we know that direct healing is going to take its own time. It's 3 months, 5 months. So it depends that which one happens first. These cases. We all repeat.
So that is not an osteochondral fracture. That is not osteochondral.
No, the problem.
वहाँ पे metaphysics में भी blood supply कम है.
But problem there is it's not the biology only. The problem.
Metaphysics में भी blood supply कम है.
Yeah. And
I'm giving you example and analysis to think about.
And this is another case where 18-year-old left shoulder dentist. She is a dentist and known to one of consultant here in PGI. And this is the one case who has one of the very long follow-up. And patient had a head split. And if you look at the heterogeneity here, the head split was actually superior inferior. We can see one cephalic fragment, we can see one caudal fragment. All the previous cases which we have seen, there was anterior posterior segmentation. Here it was a superior inferior segmentation. If you look at the blood supply of the proximal uterus, this fragment is going to get blood supply from the greater tuberosity, whereas the caudal fragment either have no blood supply if there is no metaphyseal extension, or if it is there, then capsular reflection will give some amount of the blood supply. So, such case the if you so just to elaborate this kind of fracture pattern have not been reported in humans. I could not find in literature. Maybe my literature review was inadequate, but they have reported such pattern in dogs. And what they find that this fragment undergoes this segment actually undergoes avascular necrosis because this segment gets the blood supply from the GT, whereas this segment is avascular. So that is all literature which is available about such fracture pattern. And this is what we did. We did the osteosynthesis. This is the Zimmer side specific plate was used, and head fragment was fixed with high interfragmentary screw, and like protocol to the post-operative CT scan to see the reduction. Here we can see the lesser tuberosities with head. It looks, this segment looks fairly good. This part is with GT, and this also fairly good after osteosynthesis. And now we can recollect, and now we can prognosticate that probably this patient might be doing a good job, because patient is having a good attachment of lesser tuberosity on the head. But the problem that lesser tuberosity segment actually supplies the anterior 1/3 of the head, not the remaining. So this part still had a high potential of avascular necrosis. Yes, yes, there was a lot of doubt, and you are absolutely right. This patient didn't united until 8 months. So at 8 months he came, we did the CT X-ray, because she was not having a good external rotation. So there was a lot of problem in getting a good AP view in spite of internal rotating the body. So we did the CT scan, and what we find, there is a non-union here. We can see here even the tuberosity which was looking normal in the immediate post-operative CT, now we can see there is a line, and as Dr. Ravi Gupta pointed, this segment which was opened up is not uniting. And this was the outcome at 8 months. That looks very scary for a young lady, but she was not having pain. And we opted for little more observation in this particular case, because I was also not very sure that what to do in such kind of cases at this age. So we continue observation. In between X-rays, some of the X-rays are missing. So what we identify at around 12 months, that there was penetration of the screws into the head because of ongoing avascular necrosis of the head of humerus. So what we did, we removed the screws. And because there was penetration of head, as we can see the deformation of the head here, not in this plane, but here we can see deformation with the non-union. And what we did, because there are two problems, one is the AV and other is the non-union. So what we did, we remove the screws, so that will give a core decomposition kind of effect, and also prevent the glenoid erosion. And we injected the BMAP to stimulate the healing, because patient was not very comfortable with the bone graft, because she also read a lot, and she was very sure that probably this shoulder will undergo replacement because of avascular necrosis. So she was not very convinced about the bone graft, so we gave an intermediate option of BMAC. We just injected the bone marrow, make it concentrate, and our objective was to treat both the situations, the AVN and the non-AVN. And this is what we got at around 3 years after surgery. Patient regained the movement. So once vaccine start healing, the movement improved spontaneously. This is, I think I read this concept given by the Charnley way back in the book by the Charnley, that once the fraction start eliminating, patient regained the movements. And here we can see the deformation of the head. I don't know how it happened, but it recovered to a large extent. Okay, and this patient kept on following with us. Use a BMAC which we use for fracture healing and to forward. And this is what happened at 8 years. We can see some amount of avascular necrosis which has not healed. There is a little bit deformation of the head of humerus. We can also see deformation of the glenoid, but still patient is doing perfectly fine, and now she's consulting dental surgeon and pursuing her job. And if you look at the range of movement also, they are excellent. And now there are few more cases, as there was discussion I think by Dr. Mishra that about the locking plate, that these can lead to high risk of penetration because these are fixed implants. So over the years, I also had an experience of getting AV and screw penetration, although like reported in the literature that every 4th or 5th patients of mine does have AV and they have some kind of penetration of the screw. So eventually what I have done is change my protocol of fixation, and this is the case where I had a head split fracture, a fragment with GT and a fragment with LT. Here on the axial section also we can see, and this is what we done using the same rotary interval approach. And this is the construct which I use nowadays in proximal humerus fracture. Most of my proximal humerus fracture just reconstruct and fix like proximal humerus fracture, because we know that if long neck of the femur can absorb the load of the screw, why not the humerus can absorb where the neck is so short? So lever arm which working on the humerus are actually much less than what they are working on the neck head of the humerus. But the key thing that what is required is the holding the tuberosity right. And tuberosity are not going to be held by any screw. What you have to do a nice suture osteosynthesis and tag it to the screw or any other implant. But that is what I believe that now proximal humerus fracture need that. Use the minimum implant, subacromial space can be better adapted than blocking plate in these kind of fractures. And oh sorry, I forgot to mask his face. So this was the outcome of this case. He was a labor class person, and I think he also achieved a fair to moderate outcome. He had little bit loss of forward elevation, also loss of rotation, some amount of rotation, but there is no vascular necrosis. This patient is only 4 years of follow-up. I have seen a AVN even after the 8 years, so I think it still need follow-up to confirm that will that work or not. But till now, till 4 years, it's been doing well. So now come back to the same paper. If you look at that paper, look at the number of olive cases, 24. Look at the number of reverse shoulder, 4. And still they compared, and the first statement that all lead to lot of complications. So that's the problem with the evidence. So we, as a clinician, we have to understand the evidence very rightly, that what they want to say, and also read the second line and third line. And I say all the residents that please also read the full literature rather than just reading the conclusion. And if we look at the risk of osteonecrosis, yes, I can see there are so many osteonecrosis, but these all are radiological complications and they might not have clinical complications, so that also need to be seen when we are looking at the cases with the proximal humerus fractures. And this just to make resident understand that what these head split fractures are different types. These are type 1 fracture where the head fractures and it dislocates posteriorly. This is a classification by Shiver. Type 2 fracture where the split happens in the anterior posterior plane and it dislocates anteriorly. And this is a very high risk fracture pattern where we have a segment in between. It doesn't get blood supply from any of the tuberosity or any of the artery. So it carries very high risk of AV, and same is the type 4 fractures. And if you look at the blood supply, where the proximal humerus gets the blood supply, it is anterior circumflex and posterior circumflex. And what is most dominant is the posterior circumflex artery, and they supply the most of the head and greater tuberosity, whereas anterior circumflex supply the LT and some anterior part of the head of the humerus. Thank you very much.
Displaying wonderful cases and widening our audience, delegates, with your beautiful case presentation, and that the message is that the function of the shoulder not only depends on the articular surface of the humerus but also on the tuberosity. But tuberosity is the artery of the shoulder. So, as he has pointed out, the management of the various types of the split fracture, we should not rush for the arthroplasty. We should judiciously then where to go for the fixation, where to go for the arthroplasty. And wonderfully telling us the management of the contaminated fracture. Dr. Ravi has pointed out that we should judiciously do the local plates. So thank you very much for wonderful presentations. Now, please.
So, yes, age. So for me, it's the age. I think age is the very predominant factor when we are looking at the outcome of the patient, not only radiology but clinical. Any patient more than 60 male and any female more than 50 are the patient group which I have identified that they had a poor outcome, not only in the head split fracture but also in the proximal humerus 4-part and 3-part fracture. So yes.
You are saying 60 plus place, below 60 salvage. Is that what you're saying in one sentence?
Yes, yes. And head split is not different from any 3-part and 4-part fracture. They definitely difficult to reconstruct because we have to go inside the joint. They are, but if you look at the functional outcome and radiological outcome of head split versus 4-part fracture, they are almost same.
Does it mean hemi or reverse or anatomical?
Sir, I am a believer in biology, so I do stage. So first osteosynthesis, only in really old
No,
patient.
when you say hemi,
Yes.
in 60 plus,
Yes.
so what does it mean? When you say replace in 60 plus, does it mean hemi,
Reverse.
anatomical or reverse?
Reverse. Reverse. In the trauma. After trauma, if we have waited for 2 years, 4 years, then probably this rotator cuff muscles front and back, everything is undergo atrophy, and that's why I think it's better to do reverse shoulder than doing I think that is one of the biggest drawback when we are evaluating all those trials, and that's why there is a lot of dilemma and confusion that what should be done in 3-part and 4-part fracture. Bone graft. Initially, yes, I used to put bone graft, but later on I realized that there is no lateral side, and if that area heals and surgical neck heals, it's going to survive.
So you don't find heads which are so hollow that they may not hold the screws and you might need a bone graft for them to have a purchase?
So that is the key thing. I think there is a beautiful article there is a dialogue by a old lady. What he says that if you try to hold the sand in the hand, keep the hand open. More you squeeze it, more it spill out. So similarly in the proximal.
So one of our past students also once had a fracture of the proximal humerus, and it was
Multiple cases we identified that what is the percentage of the outcome. So if we have followed the 100 cases, and then we can make the assessment and just what is right and what is wrong. We cannot make through a blanket statement that is works and operating works, and in every surgeon I think there is a little bit of difference operated by my own and failed osteosynthesis operated by someone else who has not discussed the case with me. If we have discussed and transferred all the information that yes, the lubricity and rotator cuff was impaired nicely, and we can understand that this shoulder is not going to move, and they repaired with the ethibond. So I think who has done it and how is it?
invite Dr. Rajesh Kapila, Head of Department of Orthopedics, GMC Amritsar. He is very popular surgeon there, my mentor also. I had the privilege of working under him for 9 to 10 years.
Dear delegates, proximal humerus fracture is such a challenging task that
my dear friend Dr. Hariom Agarwal, my senior, my mentor Dr. Kular at the emergency and OPD. So if you look at the epidemiology, it is the second most common fracture. So basically there is no standard protocol in the literature. As you know, elderly people with comorbidity, with impaired vision, impaired of injury fall on the outstretched hand. In younger patients by osteosynthesis, these are the deforming forces. Studying for even when we were PG students, still it is going good, and the fracture is, and then it could be associated with dislocation of the head. 20 to 40 degrees so as to have a clear trauma auxiliary view, but these views normally we do not get, and this is what. So there was this head, if you can see. So some special investigation wherever required, you can go for CT angiography like in this case. And then we found that the head was stented in most of the cases for pre-op planning. So these are some of the modalities. And even in those various posterior medial, these are the 4 part, which is hardly 3%. Is safe, then your blood supply is normally not disrupted. Otherwise, the blood supply may be disrupted, leading on to AVN, posterior medial combination, and the fracture pattern. So if we may not try to do an arthroplasty if you are a replacement. Displaced fracture, operative treatment is the treatment of choice. So we all are fitting approach where 2 incisions, one 5 centimeters from the invasive approach, and secondly chances of axillary house, or it is the key landmark around which you have to bring both your tuberosities, because it is the place where there is a fracture split and the tuberosities, they are displaced. Shaft are usually not much displaced relative to each other. So the head is separated from the glenoid fossa, often 50. It is important to open the rotator interval to inspect articular surface for any loose fragments. If the femoral head is dislocated, plate placement, this is how you fix from the almost from the tip of the GT. You can put 2 K wires, and from the anteromedial shaft to the posterior medial head, or from the posterior lateral shaft to the anterior, those are placed so that we get a stable angular construct. So plate placement about 5 to 8 mm below the tip of GT. It's a hollow thing. The head is a hollow thing. You only get purchased right at the subchondral area. So you should have long screws. Just you can measure the length of the screw, and 5 mm short to that you should put your screw, and that would have a good purchase. I tell you, even in osteoporotic patients as well. Diameter of the head from A to B, and 25% of that in the inferior part. Your inferior most screw should be within a long calcar screw, and don't miss high. So it is better to be, if you have to err, you scoop over a cone. So just like a cone of ice cream, if you can see in the first slide, the scoop is well contained within the requirement of any graft, even if there is posterior middle combination, has gone down tremendously, rather to fix the plate with the shaft. So plate will not be, this shaft will not be lateralized, and then we can put the rest of the screws. Shaft, and chances of your osteosynthesis getting failed are much more increased, especially in those osteoporotic patients. So you can see on this side, on the right of the shaft, and proper placement of calcar screw. I think they go a long way in making your osteosynthesis successful. It depends upon the bone quality, the fracture pattern, and obviously the stability of your fixation. So for me, take-home message is basically, it's simply cuff and sling, and they really get a good range of motion. Elderly patients, they don't have much requirement, so they even do well with their trick movements at the shoulder. So they get a synthesis, do very well for many years. And I don't think by just thinking that this fracture because of medial combination will go into AVN, and we will have to do a for proximal humeral fractures. Rest you all know, identification of tuberosity, head to shaft reduction, and provisional K-wire fixation. Thank you so much for your patient hearing. And before I close, I invite you all to come. You will have a really nice time. Thank you so much.
What is the role of wiring supplemental conservative treatment?
When the fracture is not displaced initially, it won't displace. That is, like, I feel like that, and it has given me good results consistently.
Yes.
Consulted in AIIMS, you can't get better treatment. And रवि ने मुझे एक स्लिंग में दे दिया, सर अनडिस्प्लेस्ड है, छोड़ दो इससे कुछ नहीं होगा. मैंने बोला my shoulder hurts. I wish somebody would have put pins there. And
Yes.
it will not displace. Sorry, that's incorrect.
Sir, point well taken, sir.
Even if
Criteria in every proximal humerus fracture people are using. The Hurtle criteria is an indicator of intraoperative ischemia. It was published in, I think, 2005 or only 35. What that article states, that whatever intraoperative ischemia I picked, there is no correlation. So it's better. I have an opportunity to work with the Hurtle as well during my fellowship. Article by the Hurtle criteria that it's an indicator of intraoperative ischemia. That's all. Not the poor outcome, not the AVN. And about the calcar screw, have you ever experienced that while you have a temptation that yes, I want to put a calcar screw, and you identified that your plate is high up on the top?
Yeah. Then you have.
So it's a very common thing in the Indian population that whenever we try to put a calcar screw, it's true.
Because small heads. Our patients have small heads. No doubt the plate goes a little up.
Because it has a high risk of axillary injury if you are going through the deltoid splitting approach. These are observed even during the presentation. The using the deltopectoral approach, the proximal humerus plate, the distal end of the deltoid split approach. Later on, I realized that same can be done with retroversion of your head, and once your head is retroversion 1 centimeter, and I think it's now it should be on the CT scan, not on the
yes, definitely.
Because your GT can go posteriorly as well, which might not be
definitely.
Professor and Head Orthopedics, AIIMS Delhi, on topic non-union and failures of proximal humerus fractures. We are lucky to have.
Patiala flat is very popular in Bathinda, and I am proud to be resident of Patiala.
2-5% of all fractures, and non-union is only 1 to 7%. And the commonest site of stiffness, aggravated rehab, female 6, and soft tissue interposition. Now, most of these things are not under cases, but your treatment remains the same, and you have the black line. And you have a deltoid which is originating from the acromion and inserting on the humerus, scalloping of the proximal fragment. So the treatment options include internal fixation plus bone grafting, hemi replacement, and reverse humerus. There is a high chance of tuberosity non-union, and that results in poor function. If the length is not restored, there is a deltoid, have a very small proximal fragment. There is scalloping of the bone and the proximal side, and there is shape mismatch success rate. To give you this example, this is a non-union of a proximal. I have done these cases by 2 techniques. The first technique in the approaches are reduction and provisional stabilization by bone graft and K-wires. The difference in the size is too big. So what we do is we take a tricortical iliac crest graft and hold. This is the tricortical iliac crest graft. This is the original bone. This is the proximal fixation. So fairly good outcome after this procedure. In the case, and that's the range of motion we could achieve. It is not as good as in the first case. Directly, we take the bicipital groove as the landmark and place the anterior edge of the phalos plate parallel to. Now, you can argue why not reverse shoulder. Reverse shoulder can be fracture, cuff deficiency, very small fragment, yet you cannot have screw purchases. You have AVia. Reverse shoulder is an option, but at its own, much higher complications, and it is indicated only in tuberosity fracture, cuff deficiency, AVN, very small fragment, or easy and provides good results. Thank you very much. Intramedullary. Intramedullary, then the big part of, first of all, putting intramedullary and having a good reduction in a non-union situation, it's not a fresh fracture. Non-union, it's not easy.
You want to ask?
No, I just wanted to make a comment on this question. Actually, Dr. Vaishali has published a to put the humeral head, the fibula within the shaft. You end up devitalizing a lot of structures, and that is important in terms for the blood supply.
And pass screws through it.
I think basically the purpose behind giving rigid cortical.
Das Singh from Amritsar, in clinical orthopedics and related research, he did CT scans after 5 years of surgery.
I think most of the people, we are recommending our junior students to go through this course. And he is popularly known as father of the orthopedics for the junior students.
Hours of my life not learning anything. And believe me, in the last 3 sessions I've learned and I made those notes.
I'm an arthroplasty surgeon either. So I'm a mix of things. In shoulder scenario, I can call myself maybe a shoulder surgeon because I do the whole variety of shoulders. Always be operated, I should consider conservative or maybe fix them. So, then becomes a problem. BATHINDA arthroplasty. So I'll give a small introduction to there, because as we see more cases, as your patient become demanding, you change, and that's why for me unfixable. If I'm a good fixer, I will fix every fracture. Keep a background hemi or a reverse. But I still want to fix up to 3-part. 4-part fracture, always I keep a replacement option in my OT. Because I'm not good. I'm good enough to fix all of them or conserve them. If they're not too bad, conserve them. So probably no replacement in less than 50. But that's not the right treatment you have given. So patient being happy doesn't mean you have done a good job. So that's a wrong statement. So fix, replace, or maybe conservative sometimes. As people like me, I'm reaching there. Don't take me like conservative or no. Replace or conservative. 70-year-old who would demand treatment, that means replace or conservative. So that's my algorithm. So what are reconstructible? Something like fire. I will end up with a stiff shoulder, maybe a good function to show in a conference, but actually it is all scapular function. So in my mind, no, I don't think that is a fixable case for me. And your GT should heal. And where will it heal? It will not heal to the prosthesis, that is matter. It will heal to the shaft. So if I'm sure that a reverse shoulder replacement. Neglected trauma, yes, some of these will come. A symptomatic patient treated by conservative and then a rotator cuff, I may still do a reverse there. But generally speaking, in younger patients, hemi has a role if GT is alright. So no point in replacing heart. But 65-year-old, most people say, okay, replace karte. But then replace it like replacement of the shoulder is not like replacement of the hip. That fellow could not live with that pain because once there is a metal inside your body, it is better to be conservative and fail. It will be only pain. Khol diya or dal diya or taake laga diya. It's a tricky operation and that's what I'm going to come to. What are the tips to get it right? You will do 6 tips. If you use a good implant and do everything very well, it may still work. This is not the implant you would like to use. On the operation table, take that ahead. Otherwise on the operation table, very difficult sometimes to get the head side because head is in piece on the table before you cement your prosthesis or put your prosthesis in. And so you rest to this. It's a very good tool with us. Head size, I told you, don't confuse yourself. Don't use a big size head. You take the opposite. We don't have colored, now they are available, colored fiber wires. But otherwise, whatever you like, which one, and otherwise, it's all union. And you get tuberosity right there. It's a very biological approach to tuberosity handling. You just open up, fracture typical where this is the position. At the edge of the table, you should be able to hyperextend. And that's the way you will approach your upper case. Mark it again, and either use a small saw or and I save my axillary nerve so they don't stretch out during the heat of the surgery. At the back, which is GT, take stock of that tuberosity with the stay suture. There's too much halla about axillary broken with the artificial head and close the door. That's it. That will give me the best possibility of union of the tuberosity. So I look at the glenoid, decided, I make a mark with a cautery, what introversion I'm going to take, and then I put my trial and reduce head and tuberosity relationship. I've done nothing, I can change everything right now. So I'm quite happy with this, it looks reasonable, and I open up again, then face for the tuberosity. So that is the space for the catheter. Now this is important part done, which means I've replaced the head. The second part of the operation is very important, reconstruction of the tuberosity. Where will they? This is something you have to learn, figure out which hole where, but essentially speaking, it is going to be tuberosity to tuberosity, tuberosity to tuberosity. and then you tighten them one at a time. So I'm getting the lesser tuberosity in place now. The posterior part, that means the greater tuberosity, is still sitting at the tuberosity, suppressed binoculars, and then tuberosity. So you are controlling all the factors to the shaft is very critical for success of this operation. So even after you've done the basic recurse to deliver your head, as usual, and close the skin. It's a God-given purpose. Why I like this?
Thank you very much for such a wonderful video to highlight the
Add the graft between the implant as well as the tuberosities and the tuberosities and shaft. So that enhances the union.
Yes. I agree with you. I do it a lot of times. It just
You will throw that bone out.
agree. I'm lazy.
any question to Dr. Mehshwari sir?
So, I think Dr. Maheshwari and Dr. Ravi Gupta, they seem to be doing a good number in hemiarthroplasty. Can I ask both of you?
Trial. So visually I look at the glenoid and the head. There are marks on the implant.
There are marks on the implant also, with the cautery.
With a cautery mark there, so that my retroversion is also now fixed.
So it's very important. So when you put a trial and you decide how much out is going to be from the bone, जो भी bone आसपास होगी, उससे ये 1 सेंटीमीटर ऊपर होना चाहिए.
But number one is if it's a fresh fracture, then the tuberosities tell you because it's anatomically comes. But we should note that. Even if you're and the release be minimal, right? But at least you know it's there. So from there, it's not accurate. It's not, but it's an approximate. You cannot completely wrong.
Since Dr. Padyal is already here, I would like to invite Dr.
I think delegates might have noted that keep learning and updating yourself. If you want,
To felicitate the chairpersons. Dr. Rajesh Kapila sir.
Rajesh Hiran, Dr. Nitish Kapil and Dr. Akash Thomas.
We have been planning for reverse shoulder arthroplasty, and Dr. Mehshwari will continue.
No problem. So I think reverse shoulder arthroplasty is now in the air. I would say now, because this seems to be the only arthroplasty being done. If you talk about trauma beyond 65-70, reverse shoulder arthroplasty. No, osteoarthritis, where rotator cuff is actually intact, but the results of reverse are better. So somehow the world has now gone crazy about small. We have to get everything in that small piece of bone called glenoid. We don't have too much play to. Critical is glenoid here. So there is a small bone of glenoid. We have to get this packed and whatever screws in this chunky part of the glenoid. It is only here replacement on the glenoid side is you can have a retroversion up to 10 degree in a reverse, which you can't have in a standard shoulder replacement. It has to be neutral. But if you have a superior tilted glenoid sphere, it all creates problem because all the force goes like that, it loses fixation. 18% contact of the, when I take up a reverse shoulder replacement, can I get this on the glenoid side? If I can get, I am happy. If I can't, you can have your own go because round and round. Varus valgus has to be neutral, more or less, otherwise you can hit here and there, and more as far as possible. Depth, the cut should be 5 mm from the cuff footprint. Take the patient in. Open up this picture. This is the post-operative X-ray I want to see. How do I reach there is what is important. Now, how to plan using the inclination of the glenoid. For example, in this case, it is more or less neutral. Why I say neutral is antivert to the retrovert. X. So then I draw another line. So that's the baseline. And I draw another line because my reverse prosthesis is alright. If I am reaming and I do not remove this lower part of the bone, something is wrong, my inclination. So it just gives you that idea as a surgeon on the table. Imagine if this was retroverted like this and I ream. I will have a mental idea that I'll ream more in the front, less in the back. So all these things, that is not what helps in shoulder surgery. Shoulder is not a joint in the midline, it is oblique, so you have to correct all that. So central pec to come. It is giving me a visual idea that when I go on the table in this patient, in the AP view, I'm almost on the middle, maybe 45, 55. In that mental pictures helps you to make your entry point, which is the key point in glenoid preparation. Now that is what this CT scan tells you. The real time. So this is the line I draw. You will see maybe this is glenoid. No, this is not the glenoid. Glenoid is only this much. This is all osteophyte. So when I'm putting the wire in a reverse, you go more lower than above. So you make a circle like this, and in the middle of the circle is the right place. A little bit here and there based on your judgment on the do. So simple. Why? Look at this. They tell you that there is a glenoid retroversion 5 degree, and as you know, I don't care because 10 degrees allowed. So मेरा retroversion तो मुझे ठीक करना ही नहीं है. Then they are going to look, which means there will be a seating of 87%. Anything above 18% seating, which means contact between the base plate and the glenoid bone, should be 80%. So anything more than 80% is acceptable. So next, you can have a 3D picture. How does it look? Show me, rotate, and you can rotate all this and see maybe my screw is perforating. What you are going to see on the table, it is going to look like this. Funny, you will not even know where is the center of the glenoid. So please drill it here. Then this is the direction you are going to do. It has said that you should go like this and not like that. And similarly in the lateral view, it's giving an idea I am going more posterior than anterior. So coracoid is there, I am pointing it more posterior, not pointing in a tight space of small glenoid. Then on the humerus side, similarly they'll tell you this is the way, this is now, and see how it will look on the table. This is the bone you are going to see on the table. On the table there are going to be so many osteophytes I am going to remove, and then this is where my process is going to sit. So give you some idea about where it should sit.
So, two comments. One is retroversion 20, many people are doing. Most of the companies either have 24 mm diameter base plate or 26 mm. So what I do is, where am I? So this is one. And the second point is about anterior and posterior equal reaming.
Good tips, I would say good tips. Now equal, we all used to use those things, but now that implants are available, I trust metal more than graft. In the knees, I have gone away from using graft completely.
For coronal 4 centimeters, I can touch the tip. So it is not accurate, but at least I know that I am not completely in a wrong.
After having behind schedule this, we invite Dr. Prashant for next talk, reuse surgery, reverse shoulder arthroplasty. Dr. Prashant.
BATHINDA Orthopedic Society and Dr. Tarun Goyal for the excellent meeting and presentation. Because the way we have realized it, it's very difficult to do revisions, and if you have to revise the reverse, then it's going to be a big problem. So you got to do it properly the first time. So color is not there. My clinical training is for to introduce myself. First time for me to come to BATHINDA. Trained in Korea, then US, in Johns Hopkins, and then I practiced in Dubai with a prominent group. And special thanks to my dear friend, Dr. Vivek Bansal. We did the fellowship together, and that is the video should play. Sir. Excuse me. So you want me to play it separately? Can I connect my laptop? So sorry for this delay. This is our patient, typical reverse you would like to do. She flew in from Zimbabwe to Hyderabad. See on your screen, on both the sides, they both can have very different patterns of where minima are needed in order to reduce the chances of base plate failures. I believe in software planning, but I do also believe in a system which helps to execute your planning and put your guide wire where you have planned. So this is previous of my cases. Without VIP, it's all over the place. But since I've started doing VIP, which is the intraoperative target, I'm able to achieve. It's not too tight or too loose. Your patients are going to be fine. Setup of the instruments, I make sure that the patients completely. Also have this Fukuda retractors, and also if you see on the bottom left are those special glenoid. And I do a subscap peel, slowly external rotating here to the bicipital groove. Then this is how I use a retroversion guide, of course, intramedullary guiding system, just to make sure it is free of all the adhesions in between. Just below the glenoid, I'm releasing the capsule, and this makes sure like I have decent glenoid exposure. I'm putting my finger and palpating that inferior edge where the tricep should actually be attached. Now my retractors are coming in between, so to make sure that they are not carefully, making sure that the glenoid does not rupture completely. So this is the base plate which I use. There are different systems which are available with a central screw organized. And also at this point of time, you have to remove your posterior Homan. Otherwise, the glenosphere does not go. It can be very hectic intraoperatively. So I use an inlay or a semi-lay system. If you're not using that, indirectly put your cup and do a trial. Now again, during the trial, I'm taking all the stress. I'm pulling with my hand on the right side and left hand rotation. That is the thing in which they will dislocate. I make a couple of holes for subscapularis. This is my final implant which is going in. And when I'm hammering it down to your patients, for this part, for the first stop, my planning and how well you can execute it, especially on the glenoid part. It also, the result. Before I go to the next talk, is any more questions? Or? So it is not like patient will bring your CT scan to work, because there are certain things which it's not an extra cost to the patient. It's the same CT scan. It's just that when the technician is doing it, they will just take 0.5 mm slices and there are certain. So yes, so out of the 3 companies which are available, good. I think in the future we're going to see robots also coming in for it in order to help you, but that is something which we need to wait and see.
Yeah, the beginners can do is they peel off half of the subscapularis. So this is the first.
The exposure of glenoid is extremely important, because if there is still some labrum attached and we try to put your retractors, you end up putting your guide wire on the top. I see a lot of x-rays which have come back when the patient is having pain and we realize it's either put.
In smaller females, I have.
Absolutely.
So you use the standard head in those smaller females?
Absolutely. So it gives you better function, but the function of subscapularis in this particular case is not for stability. So I would not chase repairing subscap. I would make sure that your deltoid tension and tension coracobrachialis is adequate. For me, that is more important.
And the cuff is on the. So I have never faced this problem of attaching, and attaching is important because it wants to do this.
Not heal, we should do, considering that subscap is not going to work. Without that, reverse should be stable intraoperatively. That's what I think. I agree with you, sir.
Yeah, one thing the key
height, which are rare in my practice, but that is when I will not lateralize. Otherwise, I will lateralize, because I use a system in which I can put the humerus in inlay. So, I just run the glenoid.
Adds to the range of movement of the shoe, and it decreases the impingement.
Yeah. Pressure loss unless it's an acute fracture. So if you see this particular X-ray, this is age-related wear or osteoarthritis, and the wear pattern, this is more posterior. It's extremely important to do CT scan planning, and you need to know how the bone is in actual coronal and 3D planning system. We do have studies that indicate that measuring retroversion on 3 days and correct the deformity. Also in coronal plane, as Sir has said, this I will not spend much time on this. The base plate is going to sit in the inferior half, so you need to plan. And this can lead to catastrophic failure if you do not correct the reverse shoulder arthroplasty angle. So you need to have this knowledge, plan these cases. It really helps us because what you decide on the computer, studies have said that there is a 90% chance you're going to use that implant exactly what you have planned. So in my practice. Shortcomings, computer modeling, everything is not perfect. Still there's a soft tissue balance which is not considered here, so you need to have, intraoperatively you should not be too stringent about your planning. If it's too tight, concerns. But one of our papers, this was a few years back in JBJS, which kind of showed us that we have 31 patients and at midterm follow, we have a long-term follow for this. The survivorship is, so this is, yes, so this is one of our patients. We did the reverse on the right side. He has a hemi on the lateralized on the humerus side. So your option 2 is your metal implants. So studies which have been done on metal implants, and this is extremely encouraging because say Mr. Sir was talking about earlier, in his hands the base plate failure rate is only 6%, which is excellent, and the bone graft, we have osteoporosis in the humeral head. So this is something which we need to take with a pinch of salt. You don't want to do a surgery in which average for bone graft was more than 2 hours treatment. So you spend 1 hour more intraoperatively in each and every case. I think that's significant. Also the customized glenoid, very quickly I'll go through it, not available in India right now, but hopefully in the future it will be available. So if you have a glenoid bone loss which is like this, which is hardly anything which is left, you need to, which we published recently on customized glenoid implants with a 2-year follow-up of activity for daily living. I think that's going to be fine. But there's still, there's some challenges with this particular implant. You feel that, you order an implant which costs about 10. Exciting avenue, and I hope that we don't have to use this very often, but it comes with its own challenges. It's not a foolproof solution. Just more than 20, I would think of augmented metal implants, but we are still waiting for long-term studies to see how they are doing. The use of bone grafts do have concerns of graft incorporation, so I would do it only twice in my life. The thing you can do is, number one, you've got to get a CT scan, and there are only very few softwares which allow you to do planning, like commercial software, glenoid. And once you do that, still there is a lot of mental artifact which I struggled with. So I had to sit down with the technician for about 15-20 minutes and remove them myself. Scan and 3D CT, and you sitting with the technician and figuring it out. That's your best bet.
Brief to save some time and just take you through the key points for a successful reverse shoulder fixation and optimal positioning. You can bank upon that you'll have best survival and best functional outcomes. Indications we all know, so I'll just skip the hand of experts and not like for the beginners to do. Today, another contraindication is the lack of adequate skill. You can just make this judgment that in the first image, your central screw will sit in the center. No for the glenoid fixation. We'll look through this later on. Same way, sometimes the X-rays will not show you the exact amount and type of bone loss. So today we have CT, and it is important that you should, and you can have a look at this. Day before yesterday, we did all this planning half an hour before the surgery. Like CT was done, patient was shifted to the OT. By the time the axillary nerve, and more important in the reverse, you have a risk of superior tilt of the glenoid. But still, for acute trauma cases, as very well demonstrated by Dr. Maheshwari, because you are looking direct nerve and you don't have to worry as long as you are putting it on the coracoid. The axillary nerve we all know is at 5 centimeters from the tuberosity. So if you keep the pectoralis major as a tendon insertion, as these, use company specific zigs, know your angles, cut minimum, you can always recut. And be careful in proximally migrated shoulders. So don't overcut in the beginning, because once you do your releases, you'll find that it is opening up and there is a lot about it. If you put it neutral, you'll have a good internal rotation but limited external rotation. If you put it in 30 degrees of retroversion, posture, position of the scapula, and accordingly adjustments required for the version in every case. So humerus is not so simple that you just put in a zig and you say, okay, 20 degree kaatna hai. You try to understand. You try to understand the patient needs. You look at the patient posture, how to put them to get the best exposure. Release of the inferior labrum and the attachment of triceps sometimes helps when you have a tight shoulder and a superior migrated shoulder, but axillary nerve passes too close to it. So be careful not to use the cautery, use a number 15 blade to release it, but it will address in a superiorly migrated head that we generally come across in the rotator arthropathy cases. Mark your lines, again very beautifully elicited by previous speakers, and try to put your finger. So you can change this version. You will have this guide, you can tilt it anteriorly to have the maximum length, minimal reaming to just make the surface smooth and parallel. Don't over ream because your glenoid will certainly decrease in size. The literature supports at least 50% of seating, but everybody wants to be approach or the trans-tuberosity approach. You have the risk of superior tilt. So be careful when you are using that approach. And version does not seem to matter much. Adapt to the version that matches your fixation criteria. You should try to a little so that you get free from the impingement with the coracoidal, and you want that inferior tilt. So to conclude, you want a glenoid that is slightly inferior. It can overhang a little bit. It is inferiorly tilted, and there is like 25 degrees of retroversion. The glenoid was stable under the stress. But the like case controlled study, they have reported that 15 degrees of retroversion, less or more of 15 degrees. It was the study that I have shown that the scapula comes down and it gets introverted in according to the posture of the patient. So you try to adapt to those things, try to adapt to the demands of the patient. Glenoid, optimal positioning for active stabilization and greater neck shaft angle. So you have inserts that can change the neck shaft angle in most of the systems and restore the anatomy to the pre-morbid position of the uterus. Finally, check for the stability. So these are later on fractures and complications because just by doing this. And the nurse's maneuver, the way they lift and move the patient in the bed, try to lift the shoulder like that. If it is stable in that, you know that it's going to be. So these are the options that you have in this one system. You have so many inserts. You can lateralize, you can distalize, you can posteriorize. Know your system, know your patient.
Positioning of glenoid component. You showed 3 images. One was most susceptible, where there was inferior tilt, and second was acceptable, where it was neutral, and superior was unacceptable. So I wish to compare.
I'll come to your point. So let's say you put in the superior tilt and in comparison to the survival of the glenoid. And the studies have shown that if you have a superior tilt, it is going to fail much earlier than if you have the inferior tilt.
No sir, we are aware about superior tilt. I am only comparing was neutral is most susceptible or inferior.
Inferior tilt is most acceptable.
Neutral is eliminating the risk of superior.
No, it is not.
It should provide more abduction.
It is not. Neutral is not eliminating. Neutral is acceptable. The best is inferior tilt. They have shown it that even with the neutral there is some rocking. With the inferior tilt there is no rocking. So you want it to be at a position where the glenoid is going to last long.
Split? If yes, in what conditions?
So as I have said, it is a good approach for the fractures because
And I do not release the subscap at all. So I maybe release 25% of the subscap should be a part, so very stable.
yeah, it is.
The exposure is so deep because you are cutting nothing. I just take a little larger cut.
Invasive approach where they not removing the subscap and they are just retracting it. So you can modify your approaches. It is just like what makes you comfortable, because believe me, reverse shoulder is not as simple as it looks. Yeah. So you have to give it the best fixation. Thank you.
So I was always looking at it. We are all trained as dental doctors. हमारे प्रोफेसर ने कभी डेल्टा स्पीड की नहीं मैंने की है हमारे प्रोफेसर ने कभी नहीं की जब हम
And on the anterior deltoid, and you'll have a messed up patient. Thank you.
People in the world, they prefer deltoid splitting for fracture fixation because you can see the tuberosity is much better. But we all do it better. We do it better. So what you are trained for, you should do that.
Thank you, sir.
train yourself for other approaches.
Thank you to all our speakers for their insightful presentations and to our chairpersons for leading this session with such excellence. As a token of our appreciation,
and he's very punctual. He was here yesterday also for the mostly of the sessions, and today also. Just very thankful to stage. And Dr. Dilbans, sir, please. Asking guys, sir, for the chairing the session. Kindly come to the stage and chair the session.
Speak about proximal biceps stenosis. So proximal biceps stenosis is done for instability of long enough biceps that can happen with subscapular stenosis, transverse humeral ligament insufficiency, overhead athletes, and for correction of Popeye deformity. So case example, 28 years old national javelin player. He had a jerk in throwing shoulder, presented with pain and loss of power in throwing, dead arm syndrome. Pack of 3 test was positive. Patient is placed in lateral decubitus position, viewing from posterior portal. Anterior portal is being set. After we set, and then anterior superior portal is set. This portal is different from what we set for instability here. This portal. So that completes the cannulation part of it. Then we bring in the rope, double loaded suture anchor. 3 threads of these double loaded suture anchor are then passed and retrieved from the anterior portal. 1 thread is remaining there. It fixes the biceps in its natural tension. Before cutting the biceps, if you fix it, you don't have to worry about the tension, because if the tension is high in fixing, the patient will have post-operative pain. If the tension is low, the power will not be adequate. And it is retrieved from the anterior portal. The corresponding free limb of this suture, that is tight. So that fixes the biceps securely in its groove. And then after that, it's a 10-minute surgery. So that biceps is released from its root, and then the MRI showed torn biceps long head with retraction. Can you see the pointer? There is the retraction. It was 6-7. So the line shows pectoralis major tendon. A 3 centimeter incision is placed at the level of pectoralis major. Biceps out. So here it is adhered. So finger dissection is being carried out to release it proximally. Exercising caution while putting it medially. The area that we are interested to put our suture anchor is just the threads are separated and a proximal 1 centimeter proximal double loaded suture anchor is put. So this 1 centimeter anchor is loaded on a needle and sequential bites are taken like we do for a ligament preparation. Sequential bites are taken and it starts from the musculotendinous. One set of suture, the other set of suture limb is taken and sequential bites are put, leaving the half inches behind your double throat. So that creates 1 point of fixation of the biceps tendon. Proximal suture anchor. So one limb is used in a similar way to take sequential bites. The other limb is kept free. And one set of suture anchor pushes the tendon back to the bone, which is deep in the bone. And next, the pair of suture that finishes the subpectoral biceps tenodesis, and it's a very small incision, 3 centimeter incision if you do your dissection right. So there is no significant biomechanical differences between different.
Any question, please?
Yes, sir. Subpectoral. We start suturing from the musculotendinous junction. In the subpectoral area, you will see the biceps belly. So your suture anchor, distal suture anchor, corresponds to the musculotendinous junction. That is the natural tension of the.
Rotator cuff tears. So we all know the rotator biceps is present in almost 75% of all rotator cuff tears. As per the studies, rotator cuff tears, biceps tendinitis is present in almost 40% cases, whereas complete tear or slap lesions are present in almost 5 to 12% cases. And we can use biceps for SCR. That is the superior capsular reconstruction. You guide it a little bit, it will heal on itself and everything goes fine. We don't need to address this biceps lesion in any way except from a shiver. Tenotomy, we can do it intra-articularly, or we can come from the subacromial space in case of loss of supination, plus or minus not much, and obviously in younger patient it gives more problems, not in older ones. So this is from the subacromial space. I think we have done, this has been already discussed. I am going to skip this. In the bicipital groove again, yes, we can do that. Sir has already shown proximal technique. In arthroscopic technique, we usually do it at the level of the bicipital groove. Again, I am going to skip this. This is the video of biceps tenodesis, but again we'll go for that. We'll remove this. We'll go for the tenotomy versus tenodesis. Tenotomy advantage is a simple procedure, well tolerated, no change in rehab, and is faster return to activity. Whereas disadvantage is a cosmetic Popeye and some loss of supinous and power. Whereas tenodesis, there is length tension has to be made. The results were same. So whether you do tenotomy or tenodesis, results were same. For me, tenodesis I will go in cases of young, physically, at least as per Diorio, it is a 5 centimeter in anterior posterior or mediolateral. If there is a tear, that is a massive tear. Or as per the Gerber, if there is 2 feet of partial repair with a massive tear, it may or may not come to the footprint. Patch augmentation, plus minus, superior capsular reconstruction with biceps or with go. I'm just showing you a case. This is a patient in early 40s, not early 40s. It's around I think 48, 49. So I spend a good amount of time releasing the cuff from the subacromial space, also intra-articularly, using my RF, using my Weisinger rod, release it as much. So what I did, a traction suture. I put perhaps 2 traction suture, one into the anterior cuff and one into the posterior cuff. A shaver or a burr, so that to bring a bleeding surface over there. And start taking bites from posteriorly. Let me see. The middle one is the triple loaded one because I intend to preserve the biceps and take bites for that. And okay, so I take 4 bites from the cuff
and the two limbs of the third straight around the biceps and take another bite, so that my biceps is secured over there. I have taken the one bite and taking the other limb around and taking another. Again, once the anterior cuff is tied, then we'll go for the biceps to be knotted first, just above the biceps. Now the cuff will come above the biceps, whatever cuff is come. This is a compromised repair. I know this is a compromised repair because I have to medialize the SCR. Thanks. So now we are talking about the slap. Either a compression type injury falling onto the outstretched hand with the arm in varying degree can occur when an unexpected pull on the arm 56 and equally to anterior and posterior to the superior glenoid tubercle in 16%, and almost no patient with the biceps need to this is the before. This is basically a absent of anterior superior or a difficulty in overhead activity. Tests for me, O'Brien, again it has got a specificity of 61%, low sensitivity. Then you can go for a fixation. Type 3 is a bucket handle tear, type 4 bucket handle tear, and the tear is extending into the biceps tendon. The main indications are young males with a history of trauma, with overhead activities, and there is a decreased function. O'Brien shown in the previous talk. My all shoulder surgeries are done in lateral positions, particularly arthroscopic surgeries. So here is the video that I'm going to go through. Then you can bring a shaver to remove this. That done with a bisangular rod, you can put in an cannula. Your direct access should be there so that your angle should not be once it is debrided, bleeding surface is exposed, the slab portal made, and you just need to take a bite from posterior part, from this part which is torn. So for that, and then pass it through the slab portal. You can take the others, suture through the slab portal, and then. So tips and tricks. You need to address that. Plan your anterior superior portal properly so that your biceps should your.
Thank you, Ashish Ajare sir, for explain talk on SCR and slab repair.
In and arm in a sling. So we got an MRI done as it is usual for most cases. So this is what the MRI showed. As you can see in the X-ray by AIIMS, and there were many protocols. The most of the protocols were centered around this single point, bony defect, bony defect. So what they proposed is, you measure the defect angle and then divide it with the total. So in our case, when I measured according to the Gerber method, it came out to be approximately 27%. So now there is a limitation. When you add it to when the gamma angle is less than 90 degree, it is called a non-engaging reverse Hill-Sachs lesion. And when it is more than 90 degree, it is an engaging lesion. So, and glenoid retroversion is also important to be calculated. There is no consensus when the defect is between 20 to 40% actually. There are multiple procedures described, from McLaughlin procedure to velocity transfers, arthroscopic McLaughlin, 96 shoulders. There are some complications depending on the screw, depending on the graft collapse. However, more or less, the results have been pretty good. So what Craghart presented in the mid are the so this is what I did. The media is point is bleeding. The shaver is coming above the subscapularis from the anterior, from the portal, from the rotator interval, and this is the position. This is the position of the labrum. I managed to put 2 anchors. I couldn't find a place or capsule tissue to put another one. Is into the defect, and this is pretty much how it looked. So I had the video, but it's not visible. So now 3 years later, the result was this. The patient had, these are the sagittal scans, the position of 2 anchors, everything satisfactory. This is the 1 anchor I used for remplissage. There is so far no arthrosis, but anyways, I was not expecting one because it happens after 5 to 10 years results. And so the key takeaways are there is high prevalence of reverse Hill-Sachs lesions in posterior disc, and if it is more than 50%, you have to go for arthroplasty. However, some still would do allografts. So glenoid version and defects are also important, good results after surgical treatment. However, if it is less than 20%,
it will be taken at the end of the session.
Perfect. Thank you, sir.
Now I call the drawing of arthroscopy of North.
For inviting me. Distal humerus was done in 2020. He had marked stiffness and pain. Plate was removed in 21. After that, again marked stiffness and some ulnar nerve praxia after the removal. So after the arthroscopic arthrolysis, we start immediate mobilization. Actually, I start in the recovery room itself. The beauty of elbow arthroscopy. Another case who is, plays boxing for our country. You can see the number of medals he has got, but for the last 2 years, he was not able to play because of severe pain in the elbow. So he already had 3 steroid injections, but of no use. Range of motion was also restricted, and X-rays show. So he got full function. In around 3 months, he was back to his game. Now, how do we do it? You mark the landmarks, the lateral epicondyle, medial epicondyle, olecranon, ulnar nerve. You go deep, anterior to the middle intermuscular septum. So you have to be careful. There are vessels in, and these are the 2 basic portals by which most of the work anterior. She had pain of tennis elbow for 5 years. She had 7 injections. And then you recess the extensor carpi brevis from the lateral epicondyle. But you have to take precaution the origin of extensor carpi brevis from the lateral epicondyle. And then she is the patient next day in the ward. As we know, the tests for tennis elbow is if you do. So how do we do it, especially when you are doing arthroscopic debridement and bony work? If there are any osteophytes or loose bodies, and then in the end, brachialis. In some cases, there is so much myositis that the entry into the joint becomes difficult. So there was a lot of myositis. So I did mini open and arthroscopic arthrolysis. And when I was mentioning that, I start mobilizing. And ultimately, this is the picture at 1 month follow. In posterior instrumentation, I always tend to identify ulnar nerve by giving a small incision because I have injured ulnar nerve in 2 cases in the last almost important case now. One of the last patients, she is a young 15 years old female who had dislocated. Manipulation under anesthesia was done and they made a video and gave it to the. She was having range of motion 75 to 90 degrees. So we got the CT done. She was 15 years when she came and now she says that she wants to become MBBS also, that in elbow manipulation should not be attempted and arthroscopy is a very good procedure.
Dr. Chandrakant Pillai.
So why rehabilitation? If shoulder joint and there are less chances of the re-tear. So that's why the rehabilitation is important. Is like you all are aware about this one that tendon to the bone healing, it takes around 2 to 3 months. The poor healing occurs in the older age, above the 50 years or the 40 to 50 years or above. The larger tiers of the poor healing. Open repairs needs the longer rehabilitation period as we need to the deltoid protection as it takes 2 to 3 months, and in this period we do not need to start the active range of motion exercises. Arthroscopic repairs relatively require the less time in the rehabilitation, and we should not go too slow or the too fast in the rehabilitation, as too slow may cause the stiffness of the joint and the too fast may cause the re-tear of the repaired tendon. The total phases in the rotator cuff rehabilitation divided into 4 phases, starting from the protection of the repaired tendon and the joint to the return to the activity. The time period here given is mainly for the arthroscopic repair. In the phase 1, that lasts for the 1.5 months usually. The goal in this phase is to immobilize the immobilization of the joint, to protect the repaired tendon and the joint, starting the passive range of the motion exercises, pain control, and at the end of this phase to start control with these modalities, we can apply the TENS, transcutaneous electric nerve stimulation, and if not with the orthosis in the phase 1, we have to apply for all the times except for the exercise program. And in the phase 2, we gradually weaning of the orthosis, starting few hours in a day, glenoid cavity, and the repaired tendon will be in relaxed position. Phase 2, we start once we achieve these ranges, initial ranges in the active range of motion, and at the end we have to achieve the active range of motion in full range. Along with this, gentle. We progress to phase 3 once we achieve the active range of motion and the few strength in the isometric training. We go for the further in the advanced strengthening phase. If the patient loves to play, prevent the shoulder adhesions or the arthrosis, and to develop the chronic pain in the shoulder, that can be prevented.
Professor Tarun Goyal sir, and our chairpersons to felicitate the speakers. Dr. Nilesh sir. Speakers Dr. Skansena sir, Dr. Ashish Acharya. chairperson is Dr. H.S. Bakshi sir. As we draw this remarkable 2-day shoulder conference to a close, sir and Dr. Pankaj Kumar Sharma sir.
Conference in arranging the logistics and even arranging all the funds and everything for the conference. I would also like to thank the patron conference, and I'm very grateful to the organizing team because they have put in really hard work. All the efforts in Dr. Lokinder Singh and Dr. Lakshman and Dr. Ankit and Dr. Santosh, they have put in a lot of effort day and night. Even late during the night, they actually went back at 2 a.m. in the morning when they were arranging the transmission from the OT that night. I have the best poster presentation awards with me. So I'll announce the name and I'll request the senior members. Third place in the best poster award, Dr. Neeraj Singla conference, and the enthusiasm of the students in poster presentation was
one from PGI, one from PGI, Amtosh, congratulations to all participants and the prize winner.
Can I request all the residents of Department of Orthopedics to kindly come on the stage?
and 3. Submit and smile.